Coding for evaluation and management services can be a daunting task, but don't worry because in this video I'm going to break down all of the different concepts for you. I can't say I'm going to make it easy, but I will make it a little bit more understandable for you. If you're new here, hey, I'm Victoria. I'm a medical coder, auditor, educator, and content creator, and on my channel I provide tips, tricks, and tutorials to help you be successful in a medical coding career. If you haven't already, highly encourage you to subscribe, hit the notification bell so that you can get alerts when I post new episodes. So we have been through the ringer with evaluation and management code changes in the past few years. We've been using the same set of guidelines since 1995, 1997, and now we have 2021 guidelines, and now we've updated them for 2023. Aside from just moving from history and exam and medical decision making being the three components to determine a level of E&M, we've also done just a lot of tweaking and changes. So for example, observation codes are now absorbed kind of into the inpatient hospital codes. They're inpatient or observation care codes. Consultations have changed quite a bit. Emergency department codes have no time concept. They have to be coded based off of medical decision making. Domiciliary and rest home codes were deleted and then merged in with the home care codes. And then prolonged service codes got quite the overhaul. So it is definitely worth checking out if your CPT book this year came with the Evaluation and Management Compendium. It's not a huge book, so if you want to get the best updates on what changed with the Evaluation and Management series and CPT, this is your best bet. Not the most interesting material, but it's not a huge book and it doesn't take that long to read through it. Also, I want to shout out NAMUS. They have created some wonderful score sheets, and I will link them below for coding some of the different evaluation and management services now, because the AMA, as the date of this recording, has not updated the score grid that they had previously given us. So in order to meet a level of service, when we're looking at these E&M services that are leveled, we have to either meet the time or the medical decision making, except of course for emergency department, which is just medical decision making. So we have to meet two of these three components, meet or exceed, in order to hit a certain level of service. We have three elements of medical decision making: the number and complexity of problems addressed, the amount and or complexity of data to be reviewed and analyzed, and then the risk of complications and or morbidity or mortality of patient management. Today we're going to focus on number and complexity of problems addressed, but I do want to talk a little bit about morbidity and mortality. We hear those words morbidity and mortality a lot in the evaluation and management guidelines. Morbidity is kind of the state of being unhealthy with a certain condition or a certain situation. So when we talk about morbidity, we're kind of talking about how potentially sick is this patient going to get, whereas mortality is the risk of the patient dying. So when we look at that, remember, morbidity, risk of how sick that patient is going to get; mortality, risk of the patient expiring. For our number and complexity of problems addressed, we have minimal, low, moderate, and high. Those are our different levels of number and complexity of problems. And remember, they're problems addressed. They can't just be problems that exist for the patient. It has to be problems that that provider addressed during that encounter. So how do we figure out if we have the minimal, the low, the moderate, or the high? Well, there's different criteria. Minimal only has one criteria that you would need to meet. Others have different things. There's different concepts. You don't have to meet all of them, but it says or. You can have this or this or this or this or this. And it doesn't mean you have to meet all of them. It just means you have to meet one of them to hit that level. Minimal is one self-limited or minor problem. Now, we have definitions for all of these from the AMA. I will link below the 2023 E&M guidelines that they have provided for us. I have mine just loose, but I'm thinking I should probably invest in actually having these printed and bound because I lose my pages as I'm flipping through them. Now, I'm sure some of you are going to ask me, Victoria, do I actually have to read through this entire guideline booklet? Yes. Yes, you have to read through this. I'm not saying you have to commit everything to memory, but you do have to read through it, and you do have to reference back to it when you're coming across those questions when you're coding evaluation and management services. So our definition of what is a self-limited or minor problem. It says a self-limited or minor problem is a problem that runs a definite and prescribed course, is transient in nature, and is not likely to permanently alter health status. So we're talking things like a common cold, diaper rash, mosquito bites, really minimal problems. Now the next level up is low, and low, there are 5 different ways you can meet the criteria for a low level of complexity of problems addressed. Those self-limited or minor problems, if you have 2 of them, you hit the criteria for low. or if you have one stable chronic illness. So what is the definition for a stable or chronic illness? It's one where a problem is expected to have a duration of at least a year or until the death of that patient. And when we say stable, stable doesn't mean that they're staying the same necessarily. So stable means the patient is not at their treatment goal. So say, for example, you have a patient who has high blood pressure, and every time they come in, they still have high blood pressure. Well, even though that's staying the same, that doesn't necessarily make it stable if their treatment goal is to be within normal range of blood pressure. So if the provider said, hey, your treatment goal is to have your blood pressure under 120/80, and they're consistently at 140/100, even though they're consistently at that, they're not at their treatment goal. So they're not considered stable. That would be considered an unstable illness. So the benchmark is them being at goal for it to be considered stable. The third way we can meet the criteria for a low is if we have an acute uncomplicated illness or injury. So acute is something that is recent or it's short term, it's a low risk of morbidity, and there's little to no risk of mortality with treatment. The patient is expected to have a full recovery without any functional impairment. It continues to say that a problem that is normally self-limited or minor but is not resolving consistent with a definite and prescribed course is an acute uncomplicated illness. And they do give us some examples. They say cystitis, allergic rhinitis, or something like a simple sprain. New for 2023 is we can also hit the low criteria by getting a stable acute illness. So basically, this is an acute condition which is improving but has not yet fully healed. Like maybe if a patient had a laceration and it's still improving but it hasn't like fully healed up yet. Or maybe if you have like an upper respiratory infection, it's getting better, but again, you're not completely recovered. That would be that stable acute problem. Heading in the right direction, but not completely there yet. Also new for 2023 guidelines is we can meet low by having one acute uncomplicated illness or injury requiring hospital inpatient or observation level of care. So again, acute problem, recent, new, short term with low risk of morbidity for which treatment is required. There's little to no risk of mortality with treatment, and full recovery without functional impairment is expected. And the treatment is delivered in either the hospital inpatient or hospital observation setting. Now, we don't have any examples from the AMA. In fact, they took out all of their examples that they used to have in the CPT book for E&M are completely gone for the 2023 edition. But I'm kind of thinking maybe something along the lines of like a fainting spell where the patient passed out maybe from heat stroke. We can't really treat them in like an urgent care, right? But maybe they need to go to observation and they're expected to recover in a short period of time and be fine, but they need to be treated in that care setting. I think that criteria might be one that we don't see as frequently as some of the things like the chronic conditions that are stable or unstable. So those are our low-level criteria. The next level would be our moderate. We also have 5 different ways we can meet the criteria for a moderate number of problems addressed. The first is if we have 2 or more stable chronic illnesses. So if the patient has diabetes and hypertension, boom, you're there. The next possibility to hit moderate is an undiagnosed new problem with an uncertain prognosis. The example they give this for us is a lump in the breast. The definition is a problem in the differential diagnosis. So we don't have the definitive diagnosis, we're working up with a differential. And it represents a condition likely to result in a high risk of morbidity without treatment. Honestly, I think this could even be something like a stomach pain where it could be a number of things, but we don't have that definitive diagnosis yet, but it's probably something that we're going to need to treat, right? The next way we can hit moderate is one that I still even myself struggle with sometimes, and that's acute illness with systemic symptoms. That systemic thing is really something that holds people up, and I've had quite a few providers debate this with me as well. The AMA definition says that this is an illness that causes systemic symptoms and has a high risk of morbidity without treatment. And it says these systemic symptoms, remember it has to be an acute illness with systemic symptoms for this category, Systemic symptoms are not general symptoms. So it can't just be that the patient has this acute illness and they also have a fever or body aches or they have fatigue. Those are general symptoms. So a patient who has an upper respiratory infection and they also have fatigue, that doesn't count as an acute illness with systemic symptoms. It counts as an acute illness, but not one with systemic symptoms. The systemic symptoms cannot be general, but they can be for just a single system. And the examples that the AMA gives us are pyelonephritis, pneumonitis, and colitis. And then the fifth and final way we can hit the moderate level is if we have an acute complicated injury. This is defined as an injury that requires evaluation of other body areas or systems that aren't directly involved with the injury. So the injury is extensive, or we possibly have some extensive treatment options for that injury. Now, it used to say that an example was a head injury with a brief loss of consciousness, but they took that example out for 2023, so I don't know if that's not a valid example anymore or what. It's probably been addressed in some sort of AMA Q&A session, webinar thing somewhere, but not one that I've had the chance to view then, I guess, myself. Now, we only have two different ways we can hit a high complexity. Now, just as a reminder, the higher complexity, the higher the potential level of service might be, the higher the payment is going to be. So generally speaking, the majority of patients are going to be kind of in that middle level, and then there's going to be a lower amount of them that are going to hit that higher criteria. We'll talk more about this when we go over putting everything together and how to come up with the full level of service. The first way to hit high is a chronic illness with a severe exacerbation, progression, or side effect of treatment. So this could be a severe progression of a chronic condition. It could be that we have some potential severe side effects of the treatment options that we have to consider for this particular condition, or it may require an escalation of care. How do we differentiate what is severe? Because remember, as coders, we can't look at things, look at the data and go, oh yeah, this is severe, this isn't, this is mild, this isn't. It has to be based off of the provider's documentation. So the provider, I always say, put in there severe. If you want that credit because this is a severe patient, it has to tell the tale in the documentation. Don't just say it looks like a duck and it quacks like a duck. You have to say that it is a duck. One that comes to mind that I would see a lot in the inpatient setting is these patients with COPD exacerbations. So we could have a potentially higher level of service from a patient who's just having a mild or moderate exacerbation of their COPD versus a patient with a severe exacerbation of their COPD. But again, it needs to differentiate clearly in that documentation. This is a severe exacerbation. Now, last but certainly not least is an acute or chronic condition that poses a threat to life or bodily function. And let's just run through the AMA definition, and it states that this is an acute illness with systemic symptoms, an acute complicated injury, or a chronic illness or injury with exacerbation and/or progression or side effects of treatment that pose a threat to life or bodily function in the near term if it's not treated. Some symptoms may represent a condition that is significantly probable and poses a threat to life or bodily function. So these may be included in this category when the evaluation and treatment are consistent with the degree of potential severity. What that means is if we're considering a condition and we have to work it up like that patient might have that condition, like for example, a heart attack, if we really think this patient might be having a heart attack and we're working it up, even though maybe it turns out that they just had anxiety, we still did the same exact work we would have done if they had a heart attack. So it still meets that criteria per the AMA. I'm sure there's some crappy insurance companies out there that will definitely disagree with that thought process, but we're talking about the AMA definitions. Some examples are if a patient has like acute renal failure, they could potentially lose their kidney. That would be considered high complexity because that patient could potentially lose that organ. Or if maybe a patient was in some sort of work accident or MVA where they could potentially lose a limb. They're going to lose that function of being able to walk. So in that case, we would also consider that a high level of complexity. Or if there's a reasonable consideration of loss of life, even if it is potentially self-inflicted loss of life, that would also meet this criteria for this category. Now remember, these are ors in all of these different categories. You don't have to meet all of those 5 bullets listed in the moderate category to hit moderate. It has to be one of those. One, this one, or this one, or this one, or this one, or this one. So that's it for the number and complexity of problems addressed. So in the next video, we're going to cover the data portion. And I just want to say thank you to all of the subscribers and channel members for helping to support the channel. I will see you guys in the next video. And until then, just keep on coding on.